Hi. So this is my first time at Sheffield. My background's in psychology. My name is Emma Shiel. I'm with the University of Huddersfield, and I'm here today with Steve Hemingway as well. We're really lucky as well to work with Dr. Steve Louie and Dr. Fang Wang on this project. And if you can't tell by the title, we've got this kind of retrospective historical piece on the enrolled nurse and looking at how we can use that and their experiences to feed into the TNA, which is the Trainee Nursing Associate. So if you hear me saying EN and TNA, that's what I mean, the enrolled nurse and the Trainee Nursing Associate. So just a little bit more on what our study actually is. As I said, it's retrospective, so we're looking back at the education and the training experiences of these enrolled nurses, and we're hoping to feed this into the current TNA to kind of see how we can provide some informed recommendations and mould it to suit a better role. This is part of a three-piece project, really. This is the first stage with the enrolled nurses, and I'll talk about this a little bit later on, but we found that actually to bring this full circle, it would be worth talking to the TNAs as well. So we're currently also interviewing the TNAs right now, and then hopefully synthesising all of this together. Oh, the nursing associates, yeah. So there's lots of reasons why we can look at the TNA right now and how we can use the enrolled nurse within this. At the moment, unfortunately, there's a chronic gap in care, and that's because of lack of registered nurses, and the NHS are quite unlikely to recruit enough nurses to be able to fulfil this need. So this has brought this kind of interest in this work-based learning approach, which we had with the enrolled nurse, and a big reinvestment into these apprenticeship routes. So as you can tell, looking back into the enrolled nurse is actually quite timely, because the TNA has kind of colloquially been called like the second enrolled nurse, as if it's kind of come back round again full circle. And as well, we have got quite a large gap within mental health in particular, hence why we decided to look at the enrolled nurse mental health. So I'm sure a lot of you will already know what the enrolled nurse is, but just to kind of provide a bit more background on that. The enrolled nurse, it was phased out in the 90s, and it was this kind of hands-on, very experiential trained nurse that worked within the team, and they were a paid member of the workforce, and they did this course for 2 years, and then at the end of it they were then a registered nurse. And this was apprenticeship based, so you didn't necessarily need the full qualifications as you would do to become a nurse. You could kind of do a little shortcut and do it work based and do it this way. And again, they were brought in similar reasons for the TNA, which was a chronic gap in nurses. So these nurses were kind of there to be generalised, but also specific to be picked up and dropped around where we were needed in the workforce. So the overarching aim of our study was really to get this lived experience from these enrolled nurses, and then see how we can, kind of input this into the TNA and see how we can change that. So in doing that, we have rich qualitative data as part of our aims. I touched on this before about how it's a phenomenological approach. We're looking at lived experiences in particular. We're looking at the benefits of the EN and how the participants felt it could be improved, and looking at things like the disadvantages and the barriers that they faced, and seeing how we can kind of turn this into a learning curve, and we're looking at the TNA. So into our analysis, it's all very qualitative. We used semi-structured interviews, so it's all very open questions. We did kind of have like a bank of questions that myself and Steve came up with, informed with the literature as well. But we let every participant kind of be unique and tell their own stories. So every interview kind of looked very different to each other, but they all had the same kind of underlying themes in the end, which was quite interesting. And we used Braun and Clark's analysis, which I'll get onto in a little while, to analyse this as well. So we got we got our ethical application done by the University of Huddersfield, and they approved it very quickly. And you might have seen it out on LinkedIn. I kind of posted it everywhere possible. So LinkedIn, on Twitter, which is now called X, on Facebook, everywhere possible. We sent out all of our flyers, and we were just looking for enrolled nurses just to come tell us about their stories, and then see if they knew anything about the TNA and if they could provide us any feedback on that as well. So from this, we got 9 participants, 5 males and 4 females. We did start with kind of just wanting mental health nurses, but because there was quite a paucity in these participants, we actually ended up having a couple from learning disability as well, just to make our participant pool a little higher. With qualitative studies, you do normally have a lower participant pool because otherwise you can have quite a lot of data to work through. So we didn't mind having 9, and I found that it was quite a nice number to have considering the transcriptions and all that kind of side of it. I've just stuck at the bottom here. These are all of the job roles that these people either are still in now, or if they're retired, these are their final roles. So as you can see, they've come quite a long way from the enrolled nurse, looking at seniors and head of nursing and ward managers and such. So this is the analysis that we followed. It was Braun and Clark's 2006 6-step analysis, which I won't go too much into. I'm sure we've all heard of it before. And then these are our 4 superordinate themes that we came up with. So this is what we got from the data, and I've put it into the thematic map here just to kind of show you in a nice visual way how we put that. So we've got theme 1 here, which is the numbers. And they've got sub-themes of institutionalisation, expectations, the workforce and training. Got theme 2, just an enrolled nurse, which was a direct quote, which I'll get onto in a little while. And we had themes of being undervalued and hierarchy and bullying. Theme 3, which was a stepping stone. This is one of my favourite themes from the whole analysis because it was quite positive, and I'll go into that again in a minute. And we've got theme 4, which was where we directly kind of translated it to the TNA. We asked the kind of direct questions about what people thought about it and what they could do to improve it with the organisation side and the student side. So theme 1, just kind of take a deep dive into that. So I called this the numbers, and this was because this was brought up a lot by every participant. Every single person actually said we were part of the numbers, and this was a big emphasis. Everyone was very proud to be a significant member of the team, and the enrolled nurse was kind of labelled as the backbone of the team. So yeah, the training was a big part of this. This 2-year, very hands-on work-based training was a big piece of why people felt so confident to be a part of the team and why they felt like such a strong backbone to it. And they said that actually this is something that we're missing in everyday life, and that the kind of reinvestment within the TNA is such a positive thing because this work-based training gave them such a wide skill set, gave them confidence, and just felt like it was a really good way of working and learning. The workforce, I touched on this before, people felt a very big part of the workforce, and people spoke about how they weren't just trained to then learn and then disappear and go into the ether into another place. They actually chose a place where they learned. They studied there for 2 years, working every single day, and then actually when they qualified, they remained in that same workplace. So they had that first day of work actually having 2 years of practice, so they were very confident and they were able to just jump straight into it, which was a massive benefit. But unfortunately, there kind of was a flip side to this because these people were seen in work every day. They were expected to kind of function and work as a registered nurse. So actually a lot of these enrolled nurses who weren't technically registered yet were working in kind of leadership roles, taking over the ward when people weren't there, which was kind of above their competence. So this leads us quite nicely into responsibility. So a lot of these nurses felt that they had kind of too much responsibility, but this was kind of a sign of the times, saying that, well, there was a gap in care, we're not going to leave patients untended for, so of course we're going to step up. But this kind of weighed a lot on them, and it caused quite a lot of issues and tension between nurses because it was, people taking on roles that just weren't their responsibility. And this brings us into institutionalisation as well. This was quite a surprising one. We didn't actually expect this to come out, and this kind of was triangulated and brought back from our corpus linguistics, which I'll talk about in a little while. So that's what found this for us and why we realised it was such a significant theme. But a lot of them talked about, again, that sign of the times and how it was very different back then. It was very regimented. Everything was by the minute and by the hour, and it was very kind of hierarchical in that aspect. So a lot of them said that this was really a struggle as an enrolled nurse, but as well it gave them this resilience because they knew that they could go into work and know exactly what was happening every single time and be very prepared for the day. So theme 2, just an enrolled nurse. As I said, this was direct quote, and this talked a lot about how they felt valued. Despite having a lot of confidence and feeling like they were, very good workers, there was significant tension within this role and within the other workers. So the first one here, valued versus being used. I like to describe this as kind of a spectrum. We have this very useful enrolled nurse, but how much are we using them before this becomes exploitation? As I said before, we've got these workers that are kind of working above the competence and they shouldn't be. So a lot of these people were, actually being exploited and felt like they were being used. There were a few participants that said actually they didn't feel this, and it said that this kind of depends on who your team are. So this wasn't, across the board, but a good 90% of participants felt that they were kind of being exploited for their role. And I touched on this slightly before with the hierarchy. There was a lot of kind of looking down on the enrolled nurse, especially with it being an apprenticeship route. A lot of the nurses had gone through a lot of academics and had a lot of accolades, whereas the enrolled nurse, a lot of them had come from the mining background or were cleaners or hospitality or were unemployed and had fallen into this role and didn't actually expect to become a nurse but had kind of just fallen into that. So this kind of all fed into this hierarchy sense of this person who was paid less, who might not be as academic and was kind of put to fulfill a need rather than having that kind of passion in academia for nursing. And this leads us in nicely again to this bullying, and unfortunately this was really prominent. Even the people who had quite positive experiences, every participant had some kind of element where they'd met bullying, so that was really significant. And this is where we grabbed our quote from for the theme here, so I just want to highlight this because I feel like it captures the experience quite well. And it says, "There was often a frustration there. You were expected to function at the same level as a registered nurse, and then at other times you were just an enrolled nurse. When the staffing suited, you were expected to step up to the leadership, but yet any other time you were just an enrolled nurse." And I think that just an enrolled nurse, really that emphasis on just really shows how these people felt. They were the backbone of the workforce at this point, but unfortunately they were also very looked down on. And then just lastly here, we've got inequality and recognition of their role. And I just want to touch on this again. We've got this really strong comment down here about doing absolutely everything that the registered nurses were doing, but for less pay and for less kudos. So you can really see how this tension is absolutely prominent throughout all of the data and unfortunately caused quite permanent rifts within the workforce at this time. So on a brighter note, we've got the stepping stone, which is theme 3. So this is actually quite a nice theme, and this showed the massive benefits of this role that unfortunately was phased out. So we've got progression. As I said, this was a great kind of very accessible course, and it gave people a lot of progression, a lot of things that people didn't know they were kind of capable of. And again, we've got these people saying we had an amazing set of skills that we enhanced and curated throughout our 2 years, and we just got better and better and better. And this gave people the ability to progress. If you remember back on the sample slide when I showed you who took part in this and what the jobs were right now, you can see the scope of progression they've had. A lot of them are in very high, very senior positions and have been for many, many years, and they all kind of said that was because they started at an enrolled nurse level and they kind of worked from the bottom all the way to the top. So that was fantastic to see. Again, it's this emphasis on opportunity. A lot of our participants had no CSEs, no O-levels, nothing like that. They just kind of walked into the job and tried the best, and this actually led them on a massive academic career and a great time within nursing. And again, this is reinforcing that confidence. People felt really confident that they'd built themselves up into this place. They'd had this 2 years of working and training just to start that first day and knowing absolutely everything and being kind of someone that is actually looked up to. And we had a lot of people say they actually pulled me in as a registered nurse as an enrolled nurse, over the registered nurse, because I was more in practice and I knew more, and that was kind of how it was like throughout. And again, we've got this competence, this work-based learning, this everyday coming in, repeating everything over and over and over again. People were very confident in their competence and performed very, very well. We've got this quote down here saying that this person started off as this baby nurse, and then every day as they went through each placement and each week, and when they reached that 2 years, the knowledge and the confidence and the skill set just grew and grew and grew. So we can see how the enrolled nurse actually was a fantastic opportunity, not only to make nursing accessible, but to be a fantastic way of learning as well. So this is the theme where we kind of directly transferred this to the TNA, and there was quite some positives, some negatives. So we'll start with this negative up here. As I said before about the rationale about looking at the enrolled nurse for the TNA, there's a lot of comparisons, and it's kind of been referred to as the second version of the enrolled nurse, and the participants felt exactly the same. They kind of had a lot of laughs saying, well, why don't we just call it the enrolled nurse, because it's exactly the same. And they had this quote here about it being the cheaper version, or a cheaper nursing workforce. So we need to be careful looking into the future that we're not replicating this kind of toxic mentality around having that cheaper second-hand nurse. Positive though, the enrolled nurses said that the ones who have worked with the TNA said they're very generalised but also very specific. So this was a massive benefit. A really good example was one of the participants who works in a mental health ward said they had a patient who had slashed the wrists, and instead of having a doctor come through, she grabbed the TNA, because the TNA knew specifics about sectioning and what to do in the mental health side, but they also knew really generalised things such as wound care, which could really help in that environment. So the TNA is this really great all-round role, which are very broad and can help in every way, but also knows little specifics about things as well. And then again, learning by experience. This has just been, highlighted all the way throughout as the best way of learning. It's this hands-on work-based learning. I've said it time and time again. It's just been seen as a very great way to learn. And then kind of just some more things from the participants there about how we adapt the course right now, the TNA. We had comments about making sure that the trusts and the universities who are providing the course, the organisations, are all working together co-jointly to make it as cohesive as possible, to make sure there's no gaps in the training and that we are definitely hitting every single competency and every lesson is being learnt. And then as well, just at the bottom here, it's again highlighting that importance of the enrolled nurse and why we did it. And this participant said that why we did it and why we did them things and how we did them things are all very relevant, and we had the rationale to do that, but let's kind of modernise it and put a twist on it and just upskill it a little bit and make sure that we're learning from our past. And that was a really key thing in this historical study really. It's looking back and making sure we're not repeating their mistakes again, but everything that was good, don't let that disappear. Let's make sure that we keep delivering that. So corpus linguistics, this was another area that we went into, and this was helped by Dr. Fang Wang that I mentioned at the beginning, who couldn't be here today. So corpus linguistics, I wasn't that familiar with it, so I was also learning it myself, and so was Steve. So if you've not heard about it before, I'll just give kind of a brief explanation. So it's an AI kind of search engine where you take all of your transcripts. So we took all of our transcripts, we took out all the filler words, we took out all the names, completely anonymised them, and we came up with 36,115 words. We put all of these words into this search engine, and what this did was it extracted all the key themes. So it goes through everything that you've done and all of the transcripts. It pulls everything out, anything that is spoke frequently, that co-occurs or is unusually frequent, and it takes out every single word like this that is in some sort of pattern, and it shows you it in its context. So you can choose to have 6 words behind it and 6 words in front of it. So say, for example, you're looking for the word Trainee Nursing Associate, you can say, yes, I want to find every instant of this alongside every iteration of this. So you can have TNA or NA as well, and it'll pick up on this and it'll show you the 6 words before and the 6 words after, just to give you a really nice, neat snapshot of how these words are being used. And this is an example of that. So when I touched on earlier about how we had institutionalisation brought up, we didn't realise this was a theme until Corpus showed us that. So this was a really great way to support our findings and to triangulate what we'd already found and say, yes, I'm glad we've found that because this has also picked up on it, but also here's some additional information that we might have missed. So this is just hierarchy as an option, and it shows us how we've got hierarchies, hierarchy and hierarchical. So it shows you every iteration of that word and how it's used, and this was just a really great method, and we definitely use this again. And I think, yeah, definitely watch this space for more corpus linguistics, because it's very, very interesting, and I think there'll be lots more research to do with it in the future. So I'll just hand it over to Steve here because he just wants to talk a little about the discussion. I'll pop this on you as well.
Okay. Thank you. We were just thinking that we wanted to start thinking about where we're going in terms of discussion, and this was just a very brief snapshot of the new literature. I wasn't looking back, so ours was, of course, a historical focus, but you can see that I was looking at the literature of enrolled nursing, the 2-year programme, in other contexts. Of course, we haven't had the enrolled nurse, and we talk about nursing associates, and there are some very definite differences between the enrolled nurse associates, but in terms of the programme, in terms of where they work, so much and so forth. But I was just looking at the shortage of numbers, and I think I've just given you just a small snapshot of some literature. So, shortage of staff, the value of enrolled nurses, so come on down again. They were disempowered perhaps, and not as valued certainly when the 1990s came here, and there's a lot of people here that saw that transformation in nursing where we were upskilling. Of course, people did have the future possibilities or the stepping stone to go on to do the degree, but again, it's valued when there's a lack of nurses. Just an enrolled nurse, again, studies from many countries identified role confusion and overlap with the employing levels of nurse. So, and then findings about lack of clarity. So again, I know that's historically, I think, been involved in the Nurse Associate programme in teaching it, as well as being in contact with Trainee Nurse Associates, and they are finding the fee. It's still there, but in other areas where it's called licensed practice nurse, whatever the 2-year programmes, there still is there. How it should work, I'll let you read that, and surely that is about valuing each other. It's almost a recipe for any type of work where interactions are there, but you know, there are explicit differences. Are they going beyond the role? Are they expanding the role? Yes, it does happen, doesn't it? They are there to, and maybe by expanding the role, they themselves do skill up and all those things that you were talking about. And then again, the future possibilities in terms of the stepping stone. So I'm just picking one study. By the way, part of our arm was to look at, do a review of nursing associates and the outcomes and things like that, but of course somebody's done that, which is good, but you know, we're moving on to other things. But just looking at that one, 75% of only 10 of 15 of samples said we intend to go on to the degree, so it's already a stepping stone. And I don't know about you, but certainly I've had trainee nurse associates who come both as apprentices and after just joining the main programme, and they are such excellent students, and the majority, they love the joy of learning one things which they hadn't been through. So what does that say about education? And of course it's a bridge, you know, there are bridging things there, so that and you know, about that transition. So they are moving forward, they will be leaders of the future, won't they? And it will be interesting in the future to see how this sample of nursing, we can't call them nurses, can we? I got told off quite a bit by the NMC for terminologies, but yeah, interesting.
So looking into the future, obviously not to kind of talk Steve's work up too much, but I was really happy with what we found. I feel that we've got some really good nuanced data, and I'm, you know, now carrying out the nursing associate side of it as well, which was asked by our participants. So after talking to all the participants, they all said, well, to get the full circle, you need the nursing associates input as well. So of course we went through with that, and we got the ethical review done for that and everything, and we passed, and now I'm on the 5th interview, and we're hoping to have 6 overall. I won't talk too much on that because we've not got to the analysis side yet, but again, some really interesting data coming out of that, and we hope to kind of triangulate that and support it and synthesise it together with our enrolled stuff stuff there. And again, we want to use corpus linguistics because I thought it was fantastic, and it was our first time using it, so I think we could only use it again and be better from there. And again, we want to publish this in a peer-reviewed journal as well. So yeah, really looking forward to the rest of this research, and I think once we've synthesised all of this together, I think each paper on its own is going to be very good, but I think once we reach that end goal, actually we're going to have some really great contributions to the literature. So yeah, that's all from me, unless Steve, you'd like to include anything else?
No, we are also working with Neil Brindlecombe from London South Bank, who's been embedded in a lot of history of nursing as well, and we probably will also looking to roll out some sort of evaluation of nurse associate, how they feel. And we notice this, just looking at the literature, it's been done, but maybe not specific mental health, stroke learning disability. And the other interesting thing is talk about corpus. I noticed somebody's got in vivo in your sort of programs to bring out some of those messages. But I think what we also intend to do is look at the corpus about the messages which we talked about the nursing associate program, because believe me, we had those papers and some were, can't be doing this will be the death of nursing. It wasn't exactly that, but that's like your D whatever nursing. And then as time goes on, it becomes accepted. Then you get a different. So it will be interesting. I mean, it's, again, corpus usually works with thousands of things, doesn't it? But so I think a colleague of yours has used corpus as well. I think, but Carmel, isn't she, Carmel Bond? But interesting, and I think it's good to go back. And I think there's a wealth of knowledge. So look forward to your questions.
You, thank you.
Thank you.
I've got a question, and my question is, and it touched on two aspects of your methodology. At the start, you said you was taking a phenomenological approach, which doesn't sit with a corpus analysis, which is, well, it doesn't. It's because it uses the word count. So how do you reconcile those two aspects?
Yeah, so we very much did a phenomenological project, and then as we went down the line, we were just kind of looking at new ways to kind of make it kind of more unique, I guess. And then we got in touch with Fang, and Fang was like, well, we've got this new thing that's come out, corpus, and she's kind of like the expert at that. So we thought, yeah, we could bring that in just to kind of confirm that what we found is, along the lines of what could be found in another approach, just to kind of triangulate our methods further. So it wasn't the main way of analysis, it was more, yeah, it was more of
the project, I think that's what probably the answer is.
Yeah.
And I think we did notice that although the corpus on the limited, because it was only 8 interviews of half an hour.
Yeah, a half an hour to 40 minutes.
So it wasn't a fit either. So when you get that information back, the same as in vivo, is what you make of it. But very much we went back down. Majored on more of the phenomena and a typical qualitative aspect. So you got another question?
I've got a few, but I'm not going to ask them just yet.
Yeah, it's interesting, that corpus, because I think you can have the same functionality in vivo, if I remember using in vivo.
I think you can.
You get it, so, but it's all grist to the arm, isn't it? But
there is that critique about word count, as you say, isn't there? But I think in terms of checking, as a checking mechanism, and as a triangulation of evidence and capturing something that you may have missed from your biased
Yeah.
Well, I suppose it should be position out, isn't it? I mean, we're either are we being kind of saying with these pluralist paradigms, or are we just going to kind of a pragmatic kind of methodological slurring in order to give us what we want with this, which is a bit dangerous. So that's why if you position yourself as a phenomenologist, and then triangulation as a practical level is great. It's just like it is a bit dangerous when you can position yourself in a numbers thing. And the kind of corpus linguistics, it's not a new thing. It's been around 20 years. or more, and kind of that judgment and kind of the Ancon software to analyse it.
Yeah, and I guess what we've said really is that is going to be another arm, and we kind of trialled it with this data. It didn't work as much as what brought out from just typical. So that's both.
I think really you need more data for the corpus, because when we did it, we found we got institutionalisation out of it, and it confirmed our views on hierarchy and such. But actually, when we were talking with Fang about it, it was something like 1 million words in it, and we only had 36,000. So I don't think we got as many benefits out of it as we could have done. If we had maybe 20 participants and maybe an hour's transcript with each one, I think it would have been more useful. But in this sense, it was kind of just a trial run of it, as Steve said, and it was like a new arm just to see how it would done.
Are you in danger again here of kind of that kind of positivist thing, right? If we had more, if we had a greater number of words, if we had a greater number of things, remember, if it's qualitative research.
But what does in vivo say? You can still look at the phenomenon.
Well, in vivo doesn't say anything because it's just a blunt piece of software. It's what you do with it.
Yeah, of course.
But in vivo
it's the lens that you use.
Yeah, but you're not counting. You're not counting in vivo.
I would argue sometimes even with qualitative, when you're looking at things, you are counting. You are looking at what comes out. Phenomenology, yes, it stands out differently, and I'll go back to Karen.
Counting what though, Steve?
But in seeing what comes out, in seeing what emerges, how many times things fitted a theme.
I mean, that's my point. Are you inducing or deducing?
Yeah, and we did have that, interesting enough, how things come up. We did have that conversation about whether we wanted to do a deductive content analysis and just going from the questions. At this point, what's emerged from your using your, so I guess it goes back to the lens in which you're looking at. Corpus was just introduced here to say this is another arm. This is, would you say it's phenomenology?
I think corpus is interesting because it was another way of looking at the data, and there's no kind of, despite having 36,000 words have gone into it, that's the only numerical aspect of it. So it shows you these, as you saw, the snapshot of each word of what's been used frequently or infrequently, and it shows you these 6 words. So as much as it shows you that data, like you saw the data there for hierarchy, that's only what you see. So it's still up to the researcher to say, okay, well, how do we understand this and what does this really mean? So there's still that qualitative aspect to it, despite being 36,000 words in a search engine. Actually, it's still very qualitative and it's very word-based, and we're still looking at the experience of the participant. We're just looking at the context of the word.
The lens that you look at it as well.
Yeah, very much so, yeah.
Okay, we've probably got 10. We are just eating into lunch. How about that for a metaphor? You had your hand up earlier.
I don't know who's first.
I do.
I was thinking about the sort of idea of, I'm just an enrolled nurse, or just a nursing associate, and I guess the comparison of just a mental health nurse, just the learning disability, and that kind of, and I was wondering if there's a sense in which being a nursing associate or an enrolled nurse either compounds that, or by spending more time in practice in some way diminishes that sense of just being
mitigates.
I don't know if that's something you've looked at at all, but just a thought.
No, I think because we were looking at their experience of being an enrolled nurse, I think there was definitely a shift in mentality as to where they are now, for example, being like senior or head of the ward. But a lot of them actually still said, I still feel that pain from being just an enrolled nurse, and I think it was quite a permanent damage to them, and I think it did stick with them throughout the careers, despite obviously having many accolades since. A lot of the participants still felt that quite rawly, and it was definitely shown in the interviews, yeah.
Okay, I do think there's a study in there, a separate one about where we inhabit psychiatry nurses or mental health nurses, how people put us in a position in between, so at some point, I'm sure we'll do it. Karen and Dave, and then we're going to have to stop and go and have a lunch.
I'll try and be quick. I think we really, really, really need to interview people who decided to stay as enrolled nurses, because I think interviewing only people who have moved on from being enrolled nurses, they have the drive to move up that hierarchy and then see enrolled nursing as lower down that hierarchy. Because yes, they phased out the opportunity to train as enrolled nurses, but they didn't phase out enrolled nurses. People could continue to practice as enrolled nurses until they retired, and many did because they were happy as enrolled nurses. They understood their contribution, they understood the boundaries of their role, and they liked being an enrolled nurse. And I think you're missing a huge section of the enrolled nurse experience. When I trained, like well over 40 years ago, I did the SRM program, and the only difference you would know about the people in the first 2 years of their program, we all wore the same uniform, would be that if you were doing the SRM program, you were called a student nurse. If you're doing the enrolled nurse program, you were called a pupil nurse, and you only got up to 2 stripes on that, not 3. And in actual fact, when they qualified and we still had a year to do, there was a hierarchy where these people were all qualified nurses and we were still at student nurses. So I think there's a big story here that would be really fabulous for you to hear and would really enhance what you've got here as the experience of enrolled nurses rather than the experience of people who were enrolled nurses and moved up the hierarchy.
Interesting enough, 2 people who stayed as enrolled nurses chose not to.
Yeah. Well, there's not so
In the
many
end,
of them
they
still
didn't come,
about,
they
is there,
weren't
to be fair?
There is still, yeah, it's capturing those.
Yeah,
And
because
getting 9 people was hard enough. It's far easier.
Yeah.
Yes, I'm surprised at that. I thought
It was really difficult.
We flushed as many trees as we could to see what fell out of them.
you
But
might
that's
not be able to,
fascinating.
you might not be able to get that. You might not be able to get to that population very easily at all. But I bet everyone of my generation, that's not many here, but will know people who stayed as enrolled nurses. And maybe it just needs a Twitter or a Facebook, social media. You might do this already, sort of call for recruitment.
Yeah, I agree with you. Interestingly enough, one of our participants said that she would have always remained an enrolled nurse, but she felt pushed to move on. And I think that's also a little branch that's worth exploring as well, because yeah, definitely.
Free courses as well, and what's more, you continue to get paid as an enrolled nurse while you did the top-up program, conversion program we called it.
Yeah.
Conversion.
Convert to an Ironman, yeah.
Yeah, I suppose as you've been speaking, I think into the involvement I had in negotiating the development of nursing associates, because I was involved in that sort of through partnership groups with Health Education England. I think one of the things that's come to mind is I suppose one of the things is it'll be easy to get hold of nursing associates to contribute to your research, because there's a lot more of them about currently. And they're still in the roles, they've not had as much opportunity to move on. I suppose just thinking about my experiences of working with lots of different professions, and this isn't something that is just sort of an issue for enrolled nurses or nurses. When I speak to paramedics, when I speak to psychologists, all the different professions that I support in Unite, quite a lot of them have the same comments. When you speak to mental health nurses, they'll speak about how there is the least appreciated field of practice, and then you speak to children's nurses and they have the most unappreciated field of practice, and you speak to adult nurses and they have the most unappreciated field of practice. So it's really fascinating when you kind of have that opportunity to speak from that kind of the higher level.